and welcome to the first Hopkins Hour for 2021. We hope you have had a great start to the year, and we'd like to extend a warm welcome to all of our Hopkins Centre members, partners and collaborators who are joining us today. Before we begin today's proceedings, I would like to acknowledge the traditional owners of the land on which we meet virtually today. My work office is on the land of the Yuggera and the Turrbal peoples, and I would like to pay my respects to the elders past, present and emerging. And we encourage all attendees to research the traditional owners of the lands on which they live and work. For those of you who don't know me, my name's Karen and I am the clinical lead of the Therapeutic Interventions and Practices Research stream here at the Hopkins Centre. And clinically, I'm working as the clinical lead in the ABI-TRS service at PA Hospital. And I will be your host today. I am joined by my esteemed colleagues, Janelle Griffin, who is an advanced clinician and the team leader in occupational therapy for brain injury rehabilitation at PA Hospital. And also joined by Rebecca Sini, who's an occupational therapist in brain injury rehabilitation at PA Hospital and is part of Janelle's research team. We're also joined by the Hopkins events team led by Michaela Kerr, and they are overseeing the presentation and will be coordinating the question and answer function throughout. So on to some housekeeping items. If you do experience any technical difficulties, please feel free to put a question in the Q&A function. And you can see this on the right side of your toolbar. And you might be able to see that Michaela has already put up a few reminders for people in there. So once you put your question in, one of our event team members one of them will try and assist you if possible. Now, we all know that internet connections can vary in an online environment. So if you do have technical trouble or you need to leave today's event, we are recording this, so you're free to leave and watch this at a later time. You're also able to pause the presentation at any point without losing your place. And a copy of the full recording will be distributed in the coming days for those who can't attend today or would like to watch this again later. Now, there will be an opportunity to ask questions throughout the presentation using that Q&A function, which, as we said, is on the right side of your screen. Now, the questions will be moderated by the team and we'll address them at the end of the presentation. So feel free to add some questions as we're going along, but we won't be addressing them during the presentation. We'll wait till the end. So to post your question, click into the Q&A function, enter in your name, or if you're not feeling brave, you can opt to stay anonymous if you'd like to. And your question will then be published and viewable to the audience. And Janelle and Rebecca will address them at the end. Okay, so now I'm going to hand over to Janelle, who is presenting today. So Janelle is an advanced clinician and team leader in OT for brain injury rehab at PA Hospital. And she's also a member of our PA Griffith University research team who have been investigating people's experiences of fatigue after acquired brain injury. And this research has been supported by a series of Hopkins Centre grants and actually won an award at the end of last year, which is very exciting. So I'm really pleased to have Janelle and Beck here today and so excited to hear about what they've been finding. And I will hand over to Janelle now.
Thank you, Karen, for the introduction and invitation to present today. The project that I'm presenting is on behalf of our research team, including Professor Louise Gustafsson, Rebecca Sini, who Karen said is here with me today, Dr. Ryan Bell, Dr. Emily Gibson, Dr. Amanda Piggott, Robin Franklin and Kylie Bauer. Thank you to the Hopkins Centre for providing support for this research from a Round 5 seed funding. Today's presentation will include an overview of the project plan and anecdotal findings to date, given we are in the middle of data collection and therefore not completed any data analysis. I'll also present some practical learnings that have come about along the way and how this beginning to shape and change how patients, caregivers and staff are thinking about traumatic brain injury fatigue. So the title of this research project is Exploring the Experience of Post-Traumatic Brain Injury Fatigue for Patients and Their Caregivers. Traumatic brain injury, or referred to as TBI, defined as an alteration in brain function or other evidence of brain pathology caused by an external force, is among the most serious disabling neurological disorders in all societies. Over the past decades, evidence has emerged citing fatigue as a common, long-lasting problem after TBI. It is burdensome to patients and is associated with poor outcomes. In many studies, significant numbers of participant samples of people with TBI reported fatigue's negative effect on social, physical and cognitive functioning and participation in everyday activities and role in increased work-related and other disabilities. Estimates of the incidence of post-traumatic brain injury fatigue vary from 21% to 73%, depending on the characteristics of the studied population. So, for example, the severity of injury, the time since the injury, the sampling of patients, and the methods used to identify fatigue, such as using single item or fatigue scales. The term fatigue has several meanings. It is recognised when performance of an activity results in diminished capacity for carrying out a function. Within this, physiological fatigue refers to the state of general tiredness due to physical or mental exertion, which can be ameliorated by rest, such as having a big day at work or running a marathon. A state that refers to a weariness unrelated to a previous exertion level and not ameliorated by rest is termed pathological fatigue. Despite such characterisation, post-traumatic brain injury fatigue is difficult to elucidate. This is partly due to the numerous plausible biological causes of fatigue, such as neuroanatomical causes or functional causes, psychological, psychiatric, biomechanical, biochemical, endocrine, or sleep-related causes, independently or combined, through which this symptom can evolve after brain injury. Now, this slide that's up at the moment by Molly Ava and colleagues shows diagrammatically the physiological and pathological fatigue pathways, which I find helpful in mapping the complexity of fatigue. There is still little known about which specific clinical, behavioural and physiological factors are associated with its occurrence after brain injury, nor whether fatigue remains the same in its frequency, intensity or changes over time. And finally, the overall health burden of this symptom in the TBI population remains uncertain, in addition to the burden of ongoing care for families and other significant care providers. There is very little literature that addresses caregiver burden for people with a traumatic brain injury, and even less that specifically targets post-traumatic brain injury fatigue and care burden. All these factors combined to trigger this research project. The clinical background to the project stemmed from clinicians working in the Brain Injury Rehabilitation Day Hospital, noticing traumatic brain injured patients were frequently reporting a persistent tiredness and overall failing to resume engagement in their previous activities of daily living. The patients were physically tired and or mentally tired, with limited physical and mental endurance for tasks, and often it was observed that they struggled to complete their day hospital therapy sessions. For patients with concurrent therapy appointments, the therapist with the final time slot was noticing poor patient engagement in their therapy session, but not through lack of willingness and effort from the patient. Coincidentally, a conversation with the Princess Alexandra Hospital Brain Injury Unit volunteer, Mr. Robin Franklin, who was a past patient of the unit, highlighted fatigue experiences and mapped ongoing issues for both himself and his wife in managing his fatigue post-TBI. Additionally, we were very aware that the carers, who are largely family members, reported the patients were sleeping or napping throughout the day, sleeping excessively at night, judged them to be lazy and disengaged. Tensions were brewing in the household because of actual or perceived shifts in responsibilities due to patients not participating to the level they were prior to their brain injury. Carers were feeling tired and drained, and they were reporting they were doing everything. Noticeably, there was an overall lack of carer awareness about post-traumatic brain injury fatigue and how to manage it. Oh, I just lost my point where I'm up to. Oh, sorry. What transpired was a discussion amongst the day hospital therapy team to explore the experiences of people with post-traumatic brain injury fatigue and their caregivers, with the hope that clinicians will be able to support people with post-traumatic brain injury fatigue and their carers to better understand fatigue, to feel more in control of the effects of fatigue, and to ensure they can target education and strategies for fatigue management. It is also hoped that through participation in this study, clinicians will understand the types of community services or supports outside of the PA hospital that may be beneficial to support families in reducing risk of carer burnout or distress. So overall, the aim of the study is to understand the experience of people with post-traumatic brain injury fatigue and their support needs, including the secondary impact on their caregivers. The key research questions for this study are: 1, what is the trajectory of fatigue severity in the first 12 months following a traumatic brain injury for patients and caregivers? And secondly, what are the lived experiences and support needs for post-traumatic brain injury patients at 2 time points in the first 12 months for A, patients and carer dyads, B, the patient group, and C, the carer group? So the project design and method that we're following, data collection is occurring at the PA Brain Injury Rehabilitation Day Hospital Outpatient Review Clinic. The study will adopt a mixed method longitudinal approach. Quantitative measures will be used to describe fatigue across the time points. Qualitative interviews will be used to explore the experience of traumatic brain injury related fatigue in a subset of patient and caregiver participants. So the participants, for the quantitative component, a time-based convenient sample of participants will be targeted over a 12-month period. It is hoped up to 30 patients and caregiver participants will be recruited during this time. Recruitment and data collection for qualitative interviews will seek to recruit a subset of up to 16 patient participants and 16 caregiver participants, with recruitment to cease once data saturation is reached. Our inclusion criteria for the patient participants includes that they've had a diagnosis of a new traumatic brain injury sustained within the 3 to 12 months. They've got a caregiver involved in supporting their recovery. They are able to provide informed consent, and they are aged over 18 years in age. Additional inclusion for the qualitative component is that the patient participant identifies post-traumatic brain injury fatigue on objective rating scales, which is scoring 43 or higher on one of the measures that we're using. The carer participants, their inclusion criteria includes that they're able to provide informed consent and that they're aged over 18 years in age. The exclusion criteria for both groups would be if they either have had a previous diagnosis of a traumatic brain injury or an acquired brain injury, or a past medical history which includes a chronic fatigue condition, a cardiac or pulmonary disease, diabetes mellitus, rheumatoid arthritis, multiple sclerosis, post-polio, cancer, renal failure, anemia, pregnant, or have a known endocrine abnormality. The reason being each of those symptoms or conditions have their own fatigue-related issues. The last is unable to provide written or informed consent to participate. For recruitment, a consecutive sample of participants are being recruited to the study. Patients who attend their scheduled review clinic appointments and report to experience fatigue during their therapy appointments are invited to participate in the study. Data collection is completed on the day of the outpatient appointment, where possible. Otherwise, telephone, postal or email options are offered. Patients are asked to complete 2 questionnaires. The fatigue scale for motor and cognitive functions, one, and the other is the Global Fatigue Index. And caregivers are asked to complete only 1 questionnaire, being the Global Fatigue Index. Patients who score in the mild, moderate or severe range on the fatigue scale for motor and cognitive functions are further invited to complete the semi-structured interviews along with their caregivers. All participants complete the same data collection process 3 months later. So the scales that we're using, the first one is the fatigue scale for motor and cognitive functions, also referred to as the FSMC. This is a 20-item scale that assesses overall fatigue as well as mental and physical fatigue, identifying each of these in terms of severity, being mild, moderate or severe. A Likert type 5-point scale ranging from does not apply at all to applies constantly produces a score between 1 and 5 for each scored question. The FSMC categorises level of fatigue into no fatigue, which is a score less than 42, mild fatigue or moderate fatigue, which is a score over 53, or severe fatigue, which is over 63. The questionnaire takes approximately 10 minutes to complete. Scale, the Global Fatigue Index, which was designed by Belzer, uses normative data. Normative data for patients with a traumatic brain injury. The GFI measures fatigue across 4 dimensions, which is severity, distress, impact of fatigue on various activities of daily living, and timing of fatigue. The scores range from 1 to 50, and the questionnaire takes approximately 10 minutes to complete. And this scale, the GFI, or the Global Fatigue Index, is also used with our carer participants, and we use normative data for healthy subjects. So the qualitative data, we'll also be doing semi-structured interviews using an interview guide to ensure consistency of interviews. Interview questions being developed in consultation with our citizen researcher on the research team. The interview questions intentionally explore the contextual nature, including environmental, relational and recovery factors, and functional implications, including self-care, productivity and leisure aspects of fatigue. And field notes that being taken, and interviews are audio recorded. Descriptive analysis will be used to report participant demographics and quantitative data according to participant groups at various time points across the 12 months. Change in fatigue ratings for both groups will also be described. Qualitative data from the semi-structured interviews will be analysed, applying the interpretive descriptive approach. This approach is considered appropriate given the clinical nature of the study and the aim to develop resources for practice. As prior knowledge of fatigue post-TBI is limited, particularly for the caregiver group, an inductive approach to data will be taken and results will be reported using the consolidated criteria for reporting qualitative studies. Quantitative, qualitative and demographic data will be linked for each patient carer dyad and analysed according to the 2 time points. This would describe a trajectory of fatigue issues for patient carer dyad and the context in which they occur. In turn, this may indicate the appropriateness of support or intervention options along the continuum for patients and carers, depending on contextual factors. Data will be analysed as separate patient and carer groups to describe unique experiences of these groups at the same time points. Now, the project is very much in the data collection phase, and subsequently, as I said earlier, there's no data analysis available at this point. However, we have anecdotal findings, and that's what I'd like to present now. So firstly, I'm going to report on what patients have reported to us, so what they've said to the clinicians and to the research team. And firstly, they've confirmed that post-traumatic brain injury fatigue is present within the first 12 months following injury. It's not just something that we're reading in the literature, they're confirming it to us. They're also presenting to us that there's great variations in intensity and the impact of that fatigue, and they're reporting it to feel very different from one person to the next. There's differences, as I said, how they are feeling it, but primarily it's physical, mental and psychological in report, and they're not happy to have it at all. They describe it as debilitating and consuming and the worst part of their recovery. They describe it as a barrier to being able or feeling able to do a lot of their previous roles. and they did not know to expect fatigue to the degree that they are experiencing it. And they don't recall being told about fatigue while they're in hospital, nor aware of it until they were discharged from hospital. And also then we've got notes on what the caregivers have reported to us. Well, they reported little, thanks Karen. Karen's just popped up some slides. So some of the comments that patients have reported to us that they've said in relation to how they're feeling their fatigue, and these are quotes that have been taken from the audio recordings. They're describing it as tiredness. That would come around during this time during the day, whether I'm actively moving or doing any type of physical exercise, it won't matter. I'm still fatigued and tired. Others describe it as I just want to doze off and go to sleep. Probably if I'm doing tasks, I'll try the task and then I'll just go to sleep. The concentration is really bad. Another person told me I just can't focus, so I'll just zone out for a little bit. And another said, in terms of the home, the fatigue has had a big effect on looking after my son, so I'll try and pass the duties on to my wife. So patients are very much feeling that fatigue and have their awareness at their level, they're definitely reporting it. So similarly to the patients reporting fatigue, the caregivers have told us what they're experiencing. Now telling us they have little to no awareness or knowledge of post-traumatic brain injury fatigue prior to their family member experiencing it. Now they're very aware of or have noticed fatigue being present in their family member, and they report it as physical fatigue, mental fatigue and psychological fatigue, mostly described as impacting mood and people just not being their usual self. They're aware that the patient is not engaged in the same roles to the extent they were prior to their TBI, and mostly not concerned about this in lieu of just wanting their family member to get better and back to their usual self. The caregivers are aware they are doing more as a consequence of the patient having fatigue, but overall they're not begrudging this and they're just remaining hopeful that things will return to normal soon. There's a tendency to let the patient do what they can or what they have capacity to do, and then the carer does the remainder, so still allowing that patient to have that autonomy. And they try to be sensitive to not let their family member, their patient, feel worse about having fatigue and the impact of this. So some of the comments that the caregivers have given, they've described fatigue as he didn't have a sleep pattern. For at least the first 2 to 3 weeks, he was like a walking zombie. I was also told things started to get back to normal, so it's just really progressive over months. Others described the fatigue, oh, it was insane. There was no rational thinking. He couldn't process things because he was that tired. And then he was frustrated. He was frustrated because he was tired, and he was tired because he couldn't sleep. So it was like a vicious circle, vicious. He'd spend all day in bed, but there wasn't a lot of sleep. I'd come in and check on him, and he'd been lying there awake, pissed off, annoyed that he wasn't asleep. He was angry at himself, and he was angry at the situation, angry that he'd had an accident. He can't concentrate, so if he hasn't had a good sleep, he was really forgetful. He can't concentrate. He's just a bit of a mess. We were told people want to put things back to normal, so he'll give everything a go. He'll push through, push through. And that concept of pushing through fatigue came through very strongly in all the interviews. Another person told me, so I'd say, in regard to roles and responsibilities, they've at least doubled. I was told, oh, look, it's tough. You know, it's really hard to deal with someone who's very much fatigued, and I'm quite tired. Me and fatigue, I was an international flight attendant for 11 years, so me and fatigue kind of go hand in hand, but to have 2 parents not on the sleep train, it can be quite tough. I can tell he feels bad and he'll do as much as he physically can. Sometimes I feel angry and annoyed because I'm like, are you serious? I've been up since 3:30 with a newborn baby, and he says he's up and he might be lying in bed, but I'm up, like I'm making coffee and feeding the baby and all of that. And the final comment was, he gets so highly strung and moody, he just complains that his brain doesn't switch off. So overall, what we were hearing from the caregivers is that they are seeing fatigue, experience fatigue, yet they're being very mindful of how that's impacting them. So some practical learnings, so how the staff and the team are carrying out their roles, so the direct impact of this knowledge and evidence generated from the project. Firstly, how staff are thinking and carrying out their roles for delivering practice now and in the future. We're educating patients and carers about TBI fatigue needs to happen prior to discharge from hospital and to be presented in both a verbal to allow for discussion and questions to be answered, and a written format so that there's reference material to reinforce information and or allow for it to be processed at a different rate or format, or even at a later time. The therapy team have increased their understanding of what fatigue is due to the study happening, in addition to a better awareness of the impact of fatigue on both the inpatient and caregivers once they transition from hospital to home. Particularly our occupational therapists and neuropsychologists have a very good understanding and awareness of the tools that we're using in the study, being the GFI and the FSMC for measuring fatigue. We're getting better at administering it, scoring it, and subsequently we're using the tools with our other patients. So the patients who aren't involved in the study or don't have a TBI, so our ABI patients who report fatigue. It's a good way to measure and remeasure and provide feedback in addition to help structuring their therapy goals. And the increase in awareness of fatigue and the impact, impact on patients has established better interdisciplinary systems to treat and manage patients in the day hospital rehabilitation process. For example, instead of the therapist seeing patients in back-to-back sessions on the same day, we're splitting sessions so that the patient comes in 2 times a week or in a format that's mindful to the patient's fatigue levels. We're offering combinations of, say, a physical session such as physio with OT and another session which might be psychosocial based, so social work and neuropsych, just to break up so we're not draining the person entirely. The multidisciplinary rehab management of post-traumatic brain injury fatigue has evolved to include the adoption of a cognitive behavioural approach, including cognitive restructuring, cognitive training, gradual increase in social or occupational activities, anxiety reducing strategies, teaching energy management techniques. We're having a broader discussion of fatigue impacts on our patients in our case conference, and a combined approach to managing. For example, neuropsych might be addressing fatigue management with the patients, and the social work with the carer or the occupational therapists are doing combined sessions with the patients and carers to develop routines and look at ADL management. Staff feel we have a more thorough and combined approach to addressing fatigue for our patients and carers. We're timetabling patients for morning therapy sessions rather than the afternoon to maximise patient effectiveness and satisfaction. As an outcome of in-servicing and general discussion, staff have better awareness of the impact of insomnia and sleep disturbance and the impact on therapy and ADLs. Patients who report psychological distress are routinely referred to neuropsychology for review. And it's anticipated that with an increased awareness of fatigue and fatigue-related issues, staff will foster a better understanding and acceptance of fatigue with employers for return to work to develop graded programs and flexible reorganisation of schedules to allow for fatigue management. So then with that change in implementation of this knowledge, how are our patients thinking or addressing fatigue now? We're finding patients have a better understanding of what fatigue is, including that it is commonly reported following a traumatic brain injury and that it is subjective. Through their multidisciplinary team rehabilitation program, they are being educated on ways to help manage their fatigue, including using strategies such as pacing, or efficient use of their time, or using a routine and incorporating exercise. Many people consider fatigue an embarrassment, but more so an inconvenience and something to learn to manage. The majority of patients report a determination to overcome their fatigue. Some patients report that having fatigue causes them to feel anger and a constant source of frustration, which is due to the impact that fatigue has on their ability to do what they want to do to the level they feel they should be able to do it. Some people are worried about the duration because no one is able to tell them how long the fatigue will last. They're concerned about their partners and their families and the impact on them, such as the patients seem to be very aware of the change in their level of ability, be it large or a small change. And in addition to not being able to do things, the patient does not want this to become a burden on others or increase the role and responsibility for others. And most patients identify their fatigue as something to work on in therapy, for example, education or a gradual exercise program to improve their endurance, or mindfulness to help overcome barriers, and are using a goal-focused approach to addressing it. And then the implementation of all this fatigue management, we're looking at how carers are thinking or addressing fatigue now. Carers are constructively supporting, for example, allowing the patients to do what they can and then identify when and where assistance is required, as opposed to jumping in to do everything. So they're letting their patients try to do what they can. They're working together to plan the day, to share the work and responsibilities with increased mindfulness of each other's capacity. There's an increased sensitivity and awareness of the sense of loss of role the patient has through the impact of fatigue. For example, is no longer the fun dad, they're not being able to play with their children in the park, or they're no longer the coach dad or the coach mum through not being able to coach the children's sport team, or they're not the mower or gardener anymore because they just don't have energy to do yard work. Carers support fatigue management as a goal for therapy and are generally very motivated to work with the patient and the therapist to learn and trial strategies. And carers ask for written education material on fatigue. They usually read it and they come to therapy sessions with questions or to seek clarification of the information in relation to the person with the post-traumatic brain injury fatigue. And so finally, just looking at some final impacts on our clinical practice. The staff doing the research have connected well with patients who report fatigue because it's both something the patient is experiencing, something that the team is very interested to know more about. And this creates a united interest to report on issues impacting recovery from fatigue and map progress to both evaluate the patient recovery as well as the therapeutic process so that the treating team can get better at managing post-traumatic brain injury fatigue with their patients. Patients are reporting on their fatigue often, and this is changing the way that their therapy programs evolve. For example, we're reducing physical fatigue through improving endurance and exercise tolerance. Establishing routines and structures for the day results in better tolerance to complete tasks, which is impacting cognitive and psychological fatigue status. And the therapists modify or enhance the program in line with improvements in fatigue. An anticipated outcome is the development of resources to guide therapy programs with examples of interventions proven successful to use with subsequent patients, along with written education materials developed by our patients for our patients with vignettes of patient journeys to encourage others. That's it. Thank you very much.
Brilliant. Janelle, thank you so much. All right, so thank you, Janelle. That was actually a really interesting presentation, and I'm looking forward to seeing some more of your results as they slowly start to come in. That's brilliant. And congratulations to your team as well, because I'm sure it's a big combined effort.
Hard-working team, very good.
All right, so now everybody, we have some time for some questions and answers from the audience. So if you haven't yet put a question in the Q&A function on the right-hand side, we now welcome you to do so. You can also follow along with the questions in the Q&A function if you'd like to see what people have submitted so far. So we'll just give you a minute to pop those questions in, and then I'll be back with Janelle and Rebecca and they will get to answering some of these. So we'll just give you half a moment. All right, hello everybody. I'm going to ask Markala to show our wonderful talkers or presenters, that's a better word for them, Beck and Janelle, and I will go through some of these questions that are coming up, if that's all right. I'm actually going to start with one that I've got on a different screen, which is asking us, how did you pick your measures that you decided on? if that's all right. If you can talk about, pick the fatigue scale for motor and cognitive functions and that global fatigue index. Can you tell us a bit about why you chose those measures?
Yeah, okay. Yes, we did a lot of research and researching into fatigue measures to try and find something that would target the data that we wanted to collect, but we found there wasn't a lot of fatigue assessments out there, and even fewer which targeted traumatic brain injuries specifically. The global fatigue index, it's one that is quick to administer and easy to follow, therefore it met with the criteria of our patient group, but also it has normative data for people with traumatic brain injury as well as for healthy people. So we were able to look at different normative data for the two client groups that we were assessing. And the FSMC, that assesses mental and physical fatigue. It's a very global tool, and it had questions that focused on evaluating the impact of everyday tasks, which is in line with what we were looking at, in line with our interview questions in our qualitative data, where we wanted to really discover how the fatigue was impacting the patient and the caregivers at home. So the FSMC was lined up really neatly with that, so it just met our needs.
Fantastic, thank you. All right, I'm going to look at our next question here, which asks, are you following any particular fatigue program for treatment, such as the facets?
Yeah, I can answer that one.
Do you want to come forwards just a bit so the camera picks you up? There we go.
The short answer at the moment is no, because obviously this is a very big question, a big topic. There's lots of elements of fatigue. So we've had to narrow the scope of the study at the moment to definitely be looking at the experience of fatigue, defining that, what is the lived experience for people and what's the impact for their everyday life, and then the secondary impact on their carers and any burden there. So we're not technically looking at implementing any treatment plans for fatigue or monitoring those at the moment, but we anticipate that by having an evidence base for the experience of it, then we can look at secondary studies in the future that might address efficacy of any treatment programs for fatigue.
And I'm sure that what you find might then determine what types of interventions you do if that experience of fatigue is so broad.
Yeah. So as Beck said, we're interested to just know, we think we know what people experience, but we don't really. So that's the information we're trying to collect. And once we know what they're experiencing at home behind the closed doors, then we'll be able to target and put an intervention in.
Because we had the same question and we went to the evidence base to find, well, what is the experience of fatigue for patients with a TBI in the literature, and found that wasn't there either. So we needed to start with defining the
build
scope,
your own evidence
build
base.
the evidence base to then inform treatment down the track.
Can I throw in a question of mine? Sorry, everyone, I'm jumping the gun and I'm allowed to. I was really surprised, well, somewhat surprised to see the people you were interviewing say we weren't told about this, or this wasn't something we were experiencing necessarily in that inpatient rehab, and no one told us. And I know from years, working on the ward, people are using this in their education. Do you think there's a mismatch in what people are recalling, or do you think it's not talked about as much? Anecdotally, do you have any thoughts on that?
I think both. I think having worked in the inpatient setting and then worked in the outpatient setting where this question really came up, I know clinically, as a clinician, I would talk about it with patients and caregivers when they're in the inpatient setting. But I think often that readiness for that information isn't there, or the level of insight that they've got into their fatigue might not be there. So in a hospital environment, understandably, a lot of people tend to say, I can't sleep because I'm in a 4-bed bay. There's a lot of other people here, the nurses wake me up for medications, or I have to be up at a certain time for breakfast, but I would prefer to sleep in if I was at home. So a lot of people are reporting, even when you say that you might be experiencing some new fatigue, they'll say it'll be better when I'm at home. Then we see them in the day hospital or the outpatient settings, and we found that it didn't get better, but their awareness of it became better because they're living their everyday life. They're trying to resume those roles that are meaningful and that are important to them, and they're suddenly noticing that there's an impact on that.
So it's definitely the lived experience,
Yeah.
and as Beck said, they're noticing this issue, and whether they were told a lot about it before, it had no meaning to them because they couldn't relate to it. They weren't feeling the fatigue, but when they got home, it was an issue. Plus, you know, they have a lot of memory problems. So, and we do give them a lot of written information. So it could be a lot of issues. It could just be information saturation, or they've lost the information that we've given them.
Or it's not relevant at the time.
Exactly.
Yeah.
I think that's the main one.
All right, and I guess just that comment that ongoing education is so important, isn't it, from us?
Without a doubt, repetition of that information, but also delivering it different ways, same information but different ways, till you really target where you're going, and then you get that understanding of people.
And the better we can understand the impact of it, I think, the better we can target our information to the right context at the right time. So what do they need to know as an inpatient? Or what do the caregivers need to know to expect, potentially, and then what is best delivered in an outpatient setting as well.
I'm going to go back to I could keep actually asking my own questions, but I'm going to go back to the ones on the screen before Makali yells at me. And so our next question, I'm just going to ask them in turn, is how is fatigue related to the sleep-wake cycle, and how can one be very fatigued but can't fall asleep for a rest?
Really good question, and I can't answer it.
Not in the purview of what you're looking at.
It's not what we're looking at, but definitely in all the literature and what we're reading, there's a lot on insomnia and its relationship to fatigue. And yes, and all our patients who are stating that they've got fatigue are not sleeping well. There's no consistent pattern, or they're having trouble getting to sleep, or there's a mixed bag of issues, there's, you know, psychological or associated problems. But I don't know why they can't fall asleep when they're so tired. I can't.
We hear it a lot though.
Yeah.
People say that a lot, but I think there's just it could be medical, could be psychological. There's so many other people that would need to, as a multidisciplinary team, weigh into that. I think
we might ask Dr. Bell that one.
And that might be a good one for any of our rehab physicians to comment on, maybe in the future.
They can let me know with thanks.
Excellent. All right, so we've got some questions around the research process. There's a question here on fatigue and pain, and is there any relationship between fatigue and pain management? Is that something you guys have had a look at all?
Not what we're looking at Geraldine. I can see Geraldine sent that question in. We aren't looking specifically at fatigue and pain management. However, again, pain is something that is reported along with fatigue. So head pain, associated neck pain, or injury recovery pain. I guess off the top of my head, I would think the relationship could relate to the physical problems. Being physically uncomfortable because of the pain is preventing you sleeping well. As a result of not sleeping well, that's impacting your fatigue, or just the general, your body burning up the energy to recover. It's exhausting you from. I don't know again. It's not an area that we're experiencing, but it is definitely something that goes hand in hand in report, that people who have fatigue are reporting associated pain issues.
And potentially another big area for future research.
Another study.
Put it on the list.
Put it on the list.
All right, I think we'll keep with our clinical questions about management and then go to the research questions if you guys are happy. So clinically, this is an anonymous question. So clinically we use a range of tools with our clients, such as to help our clients understand fatigue or to help them monitor their own fatigue. Do you have any comment on the types of tools or strategies, either from the research you've done so far or from your own clinical experience of maybe some of those tools you've been using?
Yeah, sure. In the day hospital, from my experience and what I do, so the types of tools and strategies that I'm using is firstly to explain fatigue to my patients so that they understand what it is, and then it's about targeting their understanding in relation to how they're experiencing fatigue. And then they're able to tell me back why they're having this fatigue and what their fatigue is. And once we've done that, it's looking at what their patterns of day-to-day activity includes, and then looking at which strategies will work well for them. So, for example, if they're not at work or mostly or largely home-based, it's looking at routines. So when are they most energized? When do they have the most energy? For most people, it's in the morning after they've gotten out of bed. So it's looking at the routines and setting routines and establishing their timetables to target their most energized periods, and also incorporating rest periods to acknowledge that fatigue isn't necessarily something to push through as such, but to be acknowledged and to be addressed. Is that how you're managing it?
Yeah, I think that's a great overview of the strategies. I think going back to the second part of their question about the tools, I think I would say professionally, like there was probably a gap in our OT practice in brain injuries for a while before this project came about, that we weren't largely or routinely using a lot of formal tools like these to measure people's fatigue. I think it's about having access or knowledge to some of the tools that are out there, and then I guess knowing and understanding your patient or your client and their level of other cognitive thinking and processing and insight, and then using those tools at a discretionary level. I think exactly. I think for some people they can get really overwhelmed or frustrated filling out lots of paperwork, filling out things that they don't really understand what the purpose of it is. And I think our tools, we really needed things that were short, simple, and easy to understand, because we know they're telling us that there's impacts on anger and frustration and fatigue. So you don't want your tools to be counterintuitive to make someone more frustrated. However, there's a certain subset of people too that, because of their lack of insight, can't quantify that my fatigue is impacting on something if you're just telling them that that's the case. Some people respond really well to having a more formal measure on paper of a score, of these are the things where you've come up and this is the area that we think that you might be experiencing the most fatigue, and that's considered significant on this scale. And then you've got something that you can monitor over time to evaluate change or progress or the success of strategy implementation too.
Great. I have one follow-up question on that. And I know you guys aren't doing a treatment study, but from your clinical experience, do the OTs, is everyone talking about fatigue? Is it discipline specific? Do you have that coordinated way of this is the way we're going to talk about it, or the language or the tool we're going to use, or is it more an OT-based thing?
No, it's very, very much coordinated. We have case conference, regular case conference, and it would be addressed. From the medical side, the doctors are looking at medications as appropriate, or any other medical reason for the fatigue. Our social workers are heavily based in looking after the family caregiver and supporting them. Psychology, we're very lucky to have a neuropsychologist in our team, and she does a lot of work as well in that psychological space, and the OTs are doing a lot of the ADL based activities, looking at, as I said earlier, routines and structuring the day. And again, the physio, looking at that incorporation of exercise as a treatment medium to help with fatigue, to build the endurance. So very, very multifaceted approach.
Okay, so our next question, sorry, my questions just went away for a moment.
Oh, gone.
Nope, there they are. They're hiding. The next question is this one here. Oh, sorry, did you?
Yeah, that was it.
Yep. Thank you. They're just helping me actually read today. That's always helpful. Based on your current research, have you identified any trends or patterns in the timeframes in which your patients start to experience improvements in their post-traumatic brain injury fatigue?
I think it varies. I mean, the lived experience is different for everyone. I'd say from what we've looked at in the interviews so far, there tends to be that when they get home, that initial improvement in some of the contributing factors, perhaps around sleep. So if they're having interrupted sleep, or they're not finding the hospital environment conducive to a restful or quiet environment. Sometimes they notice an improvement in that first month because they find they can sleep better at home or in their own bed. But then that's only a really small part. That might get better and they might be sleeping better, but they may not find that that correlates with a huge improvement in their lived experience of fatigue too.
But on the whole, the timeframes completely unique to every individual. Some people come up for a review, 6-month or 12-month review, and they don't have fatigue. And for the life of us, we can't work out, given that injury is very similar to another injury and their circumstances are very similar to another patient. One can be greatly debilitated by fatigue and the other person not. Then it comes to looking at other factors, psychological and mental health and things like that. So to answer the question in a word, that no, there's no certain pattern or experience of time frames for recovery, but generally everybody seems, as Beck says, to pattern along differently and make recoveries dependent on their own environmental issues. So we do see an improvement in their abilities with their fatigue, but it does persist.
Yeah, that's right. I'm keeping an eye on the time. I think we've got time for 1 or 2 more short questions. Keeping on that, well, we are talking about fatigue, but clinically, are those outcome scales you used readily available?
The
2 measures you're using?
Yep, just do a Google search and they'll pop up.
Excellent. Are they things you have to purchase, or are they freely downloadable? Freely
downloadable, and I have copies of them. If anybody would like them to use them, I can send you the assessment as well as the articles and any scoring literature. So happy to do that if you want to get in touch with me.
Thanks, Janelle. And then there's a question here about caregivers. So what sorts of outcomes are you hoping to find in exploring the experience of fatigue related to the caregivers?
We want to understand what the caregivers are experiencing. We assume they're exhausted, we assume they're taking on the burden, we assume a lot of things, but we just want to know. So in a couple of the interviews that I've done, I've been surprised with this theme of the carer can see that the patients are tired and they've got this fatigue, but overwhelmingly they want them to engage in any and every activity that they can to give them a sense of purpose and normalcy. So the caregivers aren't jumping in and doing things, they're just picking up the pieces and doing anything that's left at the end. Whereas in my mind, I was assuming that the caregivers were doing everything because they had to, because the patients weren't. But most patients just want to get on with life as usual, so jumping in and doing as much as they can. So that didn't really pan out how I thought it was, so I was happily surprised. But ultimately, we want to know exactly what the families are experiencing, and therefore to be able to map then what we can do to support them, whether it's looking at NDIS funded support workers or care packages, or if it's psychological support, or just what. We just want to know what the patterns and issues are, and that will mean that we'll have a big think about how we can better support them.
And plan for that. So from an inpatient setting, if we know what the largest areas of burden are, then we could utilise those things in NDIS planning meetings or NISC meetings where we're asking for support and planning for someone's return home, what areas we may also include that we might not have thought about in the past.
Yeah, that's exciting. That's really good.
We're hoping we'll get some good outcomes.
Oh, that's lovely. I think I've just been told by Markala we have time for one more quick question. And we might talk about this sensory fatigue. So this is a message from Sandra asking, are you also looking at sensory fatigue? So sensory loss following ABI, so vision or hearing, and the impact of environment on overload resulting in fatigue. And Sandra saw a client yesterday in the community where this was significantly impacting on participation in all their daily tasks.
Yes, Sandra, we are, and we have a lot of patients who have heightened sensitivity to light, noise, activity, and it exhausts them, mentally exhausts them. So yes, we are including that cohort of people in our study, and we'll definitely be identifying what the types of fatigue people had, so we can write about that in the study.
All right. Well, thank you, everybody. I think that we will close that there because I do think we're running out of time and I think we haven't quite gotten to all our questions. So I would really like to thank Janelle and Beck and your whole team for your presentation today. It's been really lovely to see such exciting local research. I'm all excited.
Thank you for inviting us and for having us today.
And I'd like to thank everyone out there we really just appreciate you all making the time to join us today for today's Hopkins Hour. And it's been a pleasure to have you all, although it is a bit strange to be in my little office talking and not seeing anyone face to face. So thank you all for joining us online. I really hope you found the session informative and have either gained some insights to take away for your clinical practice or thinking about what we do clinically, or if we have some consumers listening, they've got some things they might be identifying with at home as well. So as I mentioned at the start of today, we will be distributing the event recording, the Q&A responses and any further materials in the coming days. And as Janelle's already suggested, if you'd like to get in touch with any of the presenters, we would encourage